Hi, everybody. Thanks for coming. I think everybody knows I'm Mike Clegg. I'm Dean of the school, and we're here for a Dean's Lecture. And usually I start this by saying that it's an incredible honor to be promoted to the level of professor at the Johns Hopkins University. It's hard to get on the faculty, and then it's even harder to get promoted. But today is a little bit different case. So we have somebody who was promoted here some years ago and left and then did us the honor by coming back, and that's Karen Davis. And she joined us last year to head the Lipitz Center and coming from a very successful presidency of the Commonwealth Foundation. So I first met Karen when I was a student, and I was impressed at that time with what a great mentor and how kind she was to me. So I'm going to do a little bit of a formal introduction just so that I cover the bases and so that everybody sort of has a sense of what Karen has accomplished. She was here for 12 years, and 9 of those years she spent as chair, and it was at the end of that chairmanship when she went to Commonwealth. And I think HPM, it's a great department, and it's a great department because it's had great leadership, Ellen and Don and Karen. And Karen, under Karen's leadership, the department greatly expanded and really recruited many of the faculty who became subsequent leaders here at the school and nationally and internationally in health policy and management. So it was in January 1 of this year when Karen formally assumed the leadership of the Eugene and Mildred Lipitz. She became the Eugene and Mildred Lipitz Professor and then headed the Roger Lipitz Center for Integrated Healthcare. And then in May, here in this room, we celebrated her induction as the Lipitz Professor. She's an international leader in the field of health policy and has particular expertise in the Medicare program and healthcare systems, healthcare financing, and delivery systems for the uninsured. Now, one of the things that I always think about as dean of the school is we're a big school, but how do we change the game? How do we make an impact that is beyond our weight? We have a lot of faculty, but we don't have infinite resources, and so we're always looking for strategic ways to make the world a better place and to have an impact. And I have to say, I was always admired Karen for her leadership at Commonwealth, where by giving away money, but not a whole lot of money, but money, that she did it in a strategic way that changed the evidence base and changed the argument about healthcare in the U.S. She's been a prolific author. She continues to write. She has over 150 peer-reviewed publications, 6 books, 50 book chapters, and recently has published in the New England Journal of Medicine, JAMA, the Annals of Internal Medicine, and Health Affairs. Now, anybody in your field would love to have a publication in one of those journals recently, and you've done them all. Before she came to Hopkins, she was on the faculty at Rice and at Harvard, and she had research and leadership positions at the Brookings Institution, and she also served in HHS, Department of Health and Human Services, as administrator of the Health Resources Administration. She has been widely honored for her work, including honorary doctorates from Johns Hopkins and the University of Maryland. That doesn't happen much, both. And last year received the American Hospital Association's highest honor, the Distinguished Service Award. Karen has always been interested in numbers and economics, and so she went to Rice. It's not why she went to Rice University, but she went to Rice University in Houston. And Rice University is always at the top of the list for the best buy in higher education. I don't know if you read those in U.S. News and World Report. And the tuition is incredibly cheap there. It's a great school, but it has a big endowment. But it used to be free. And Karen told me she was the last class that graduated free tuition, so she was just in time. And then she stayed at Rice. She had her undergraduate degrees in math and economics, and she stayed at Rice and got her PhD in economics. So it's a great pleasure and honor for me to have Karen back on the faculty and to have her here today to talk about Medicare. So Karen, thank you.
Well, thank you for that introduction, but also for being so prescient to call for a talk on Medicare today, it turns out that we've been focused a lot on the Affordable Care Act, otherwise known as Obamacare, and health insurance exchanges and the shutdown of the federal government over the debate about repealing or defunding the Affordable Care Act. But if you've been watching Washington closely, what you're now starting to hear about is the debt ceiling. And House Speaker Boehner saying the condition for lifting the debt ceiling is entitlement reform. And that's basically all about Medicare and Social Security and achieving savings. So you're going to hear a lot more about what are the issues in the Medicare program, does it need to be changed, and what are the options for doing that. So we're going to get into that a bit today. This is a subject of interest to a lot of us because if we're all lucky, we will eventually find our way onto Medicare and onto Social Security. So I'd like to talk about how well Medicare is meeting its goals, talk a little bit about the provisions that affect Medicare beneficiaries in the Affordable Care Act. It's not just about the uninsured or people under age 65. Talk about some of the future issues and challenges that Medicare will be facing and the options that are put forward for dealing with that, and then conclude with some work that we're planning to do at the Lipitz Center to move toward a high-performance health system. Well, to start with, how well is Medicare meeting its goal? Its fundamental goal was to cover the elderly. And then in 1972, people have been disabled for 2 years or more. In 1963, there was a survey of the elderly, and the basic finding is that half of all older people lost their health insurance when they reached age 65, retired, and lost their employer coverage. So you had a very high rate of uninsured of elderly people, as well as low-income people, people who were unemployed or working in very low-wage jobs. Medicare and Medicaid were signed into law in 1965, dramatically cut the numbers of uninsured. In fact, today, only 1.5% of people over age 65 are uninsured, mostly people who immigrated to the U.S. and did not acquire work histories to qualify for Medicare. So you're going from half of the population uninsured to less than 2% of the population uninsured. Now, the numbers of uninsured have been rising again, mostly as there has been an erosion of health insurance coverage through smaller employers, employers with smaller labor forces, and as more of the American workforce has been in low-wage jobs in small businesses that don't provide coverage, and that's really what has precipitated the healthcare reform. Well, most public policy is not a randomized controlled trial. So to answer the question of did Medicare work, you need a comparison group, and there isn't one. It basically covered everybody over age 65. So comparing them with people under 65, maybe there's some interesting implications there, but it's not the same as a randomized controlled trial. The first thing we know is that life expectancy at age 65 has improved pretty dramatically since Medicare was enacted in 1965. In fact, it's improved more than life expectancy and mortality rates for people under age 65. But there continue to be disparities between men and women, and more importantly, between blacks and whites on this measure of health outcome. The easier things to look at are access to care for people covered by Medicare, and particularly to look at the differences between access to care for people covered by Medicare and those covered by the best of the private insurance for those under age 65, those covered under employer-based health insurance coverage. The Commonwealth Fund started a series of health insurance surveys every 2 years, developed questions to really get at access to care. We used to measure it by number of visits, found that that wasn't a very good way of really determining and develop questions such as, did you not fill a prescription because of cost? Did you not go to a specialist when your doctor recommended it? Did you not get a recommended test or procedure? In fact, did you not go to your doctor at all because of cost when you felt like that you needed one? If you use those measures in 2012, 19% of people covered by Medicare said they had a problem accessing care, compared with 41% of people covered by employer coverage. And those rates actually are up for both groups since 2001. But it's actually not very comforting to know that a fifth of Medicare beneficiaries still, even with Medicare, have problems obtaining care. And it's certainly disquieting to know that 2/5 of those with employer health insurance coverage still have difficulty accessing care, when that's the fundamental reason for buying health insurance coverage. The other major goal of health insurance coverage is to reduce or prevent the financial burdens that can come from uncovered medical expenses. Again, Medicare beneficiaries are less likely to report bill problems, difficulty paying bills, being contacted by collection agencies for unpaid medical bills, or having to change their way of life because of medical bills, or have accumulated medical debt that they are paying off over time. Again, about twice the rate of medical bill problems for those insured through employer plans versus those covered by Medicare. Although, again, slight uptick for Medicare beneficiaries over the 2000. When you look at the care that Medicare beneficiaries receive, a recent concept that has somewhat replaced having a regular doctor is going beyond that to having a physician's office that really knows your medical history, that you can get questions answered the same day, that they help you coordinate your care, called the patient-centered medical homes. About 69% of Medicare beneficiaries say that they receive care through such a practice, about 58% of those covered by employer plans. Again, Medicare beneficiaries, about 2/3 are up to date with preventive services, less than half up to date with preventive services for those covered by employer coverage. And excellent or very good quality care. Again, Medicare more likely to report that, although some people were shocked to think that only 1/3 of Medicare beneficiaries really think that their care is excellent or very good. So room for improvement there. With regard to negative insurance experiences, did the plan not cover what you needed? It had limits, had hassles getting the bills paid. People covered by employer coverage, about half report negative insurance experiences, and about 1/3 of Medicare beneficiaries. And in fact, about 21% of people with employer coverage rate their insurance coverage as fair or poor. So whatever you think of the levels, not perfect by any means, but Medicare performing relatively well compared to the types of coverage that other people have on access to care, medical bills, having access to good quality care, getting preventive services, and rating their insurance highly. Some people talk about Medicare as a 1965 Chevy that hasn't been modernized in 50 years, but in fact, Medicare has been a major innovator over time. I see Jerry Anderson from Hopkins here, who really developed the hospital payment system called the diagnosis-related group method of payment. And that method has now been adopted by many private insurance plans in the U.S., and Jerry told me about 40 countries around the world now adopting that kind of a global case rate method of payment, depending upon the patient's diagnosis and condition. Similarly, in 1990, the DRG system came in 1983. In 1992, Medicare adopted what's called the resource-based relative value schedule. Up until that point, private insurers and Medicare paid what were called reasonable and customary charges, which could mean anything, and the more you raised the charges, the more it was customary to have high fees, to really setting a fee schedule with increases really determined annually through a formula or through a government congressional action. We're hearing a lot since October 1st about health insurance exchanges and can state health insurance exchanges work. Medicare has really run its own health insurance exchange starting in the 1980s, where traditional Medicare, which is publicly insured coverage, competes against private managed care plans head-to-head, and has had about 25 years of experience now with running a Medicare marketplace that gives choices to beneficiaries. And about a fourth of beneficiaries do choose to be enrolled in what are called Medicare Advantage private managed care plans. In addition, in 2003, prescription drugs were added to the Medicare program, and that's also offered through competing private drug plans. President George Bush did not support having a publicly provided drug benefit, so it's just private plans that beneficiaries receive. Well, as important as those changes were, I would say that the Affordable Care Act is also fundamentally of shaping the future course of the Medicare program. Everybody's focused so much on the provisions affecting the uninsured that very few people know about how much is in the Affordable Care Act that affects Medicare beneficiaries. Like other kinds of plans for people under 65, it eliminated cost sharing for preventive services. It added an annual wellness visit as well as a one-time welcome to Medicare preventive visit. But it phased out what is known as the donut hole in prescription drug coverage. So when drugs were added in 2003, basically covers has a deductible, then it covers drugs pretty comprehensively, about 75% of the expenses, and then it covers nothing at all for a period of time, and then picks up 95% of catastrophic drug expenses. So that's called the hole in the coverage, and that is phased out under the Affordable Care Act. There were two ways in which the Affordable Care Act achieved savings in the Medicare program. The first was taking 1% out of the inflationary increases in provider payment rates every year. This was a provision the American Hospital Association agreed to, feeling that their bad debts would be reduced as the uninsured were covered. So instead of, say, getting a 5% increase, they might get a 4% increase. So that's called the productivity update, meaning you have to improve productivity by 1% to maintain the same margins. In addition, there were other types of payment changes. There was a 10% increase in primary care payment rates. There are also sanctions or losses of about 1% for hospitals with high rates of hospital-acquired conditions or high rates of hospital readmission rates. And Medicare has also now implemented what is called value-based purchasing for hospitals, and will roll that out for other providers over time. But it gives bonuses effectively to hospitals with high quality scores, high patient ratings of hospitals. But I think the most important provision that really will have fundamental implications for the Medicare program is the creation of the Centers for Medicare and Medicaid Innovation, charged with testing a whole variety of new payment and delivery system approaches. I know Hopkins has succeeded in getting Innovator awards from CMMI and are participating in a number of initiatives in that program. Well, what do we know about the early results of these legislation? Certainly, the administration has been eager to put out the numbers on who has benefited from these provisions. 34 million Medicare beneficiaries receiving free preventive services, about 6.3 million beneficiaries in that donut hole, already saving about $6 billion. The most surprising early finding, though, is how flat the trends have been in the growth in Medicare outlays. In fact, the rate of increase in Medicare spending per beneficiary and in total national health expenditures per capita are growing at the slowest rate in 50 years. The Medicare Advantage savings were particularly controversial, really riled up a lot of seniors who were told that if they were in a managed care plan, their plan was going to pull out or cut benefits or raise premiums because Medicare was freezing their payment rates for 3 years until they came in line with payment for traditional Medicare. And in fact, premiums have fallen, but enrollment has risen by about 28%. And the physician deductible and premiums are also much lower as a result of this slower growth in Medicare outlays than was projected pre-reform. As a result, the solvency of the Medicare Hospital Trust Fund, the Part A Trust Fund, was extended 9 years from 2017 to 2026. And interestingly, there's some information starting to become available that things like the sanctions on hospital readmissions are causing practices to change and hospitals to really invest in transitional care or other strategies to reduce the rates of readmissions. But just to go through a couple of those points in a little more detail, but it's also intended to make you a bit skeptical about government projections. Somebody said actuaries were never fired by overestimating how much something would cost. So they've got a bias toward making sure that they're conservative and there's enough revenue being generated to cover expenses. But I mentioned that Medicare Advantage enrollment is up by 28%. The Office of the Actuaries projected that it would drop by 50%. It's a huge difference to have a 28% increase instead of a 50% decline. Currently, the Congressional Budget Office is estimating that the Medicare program will increase to about 4% of GDP by about 2040, or including Medicaid, the Children's Health Insurance Program, and the subsidies for premiums for lower income and modest income families through the health insurance exchanges will drive total spending for those health programs up to almost 8% of the gross domestic product. And it is really this chart that is precipitating this conversation in Washington about entitlement reform. But if you stare at it really closely and focus on the Medicare line, you see that it's actually pretty flat for 10 years from 2010 to 2020, and then it starts up again. But what you should know is that CBO uses a different projection methodology for the first decade than it uses for the second decade. So it bases the first decade on what's been happening lately and extrapolating that. It bases future decades on a longer historical rate of increase. But if you really look at what's happened since the Affordable Care Act, Medicare spending as a proportion of GDP is really quite flat. And at first, the actuaries said, well, you know, that's the recession. People were out of jobs, and you could kind of see how that might apply to total health expenditures as people lost health insurance coverage, quit going to the doctor, quit going to the hospital. It's never clear to me why it affected Medicare beneficiaries who didn't lose job, and it wasn't clear to me why it affected spending in 2020. And in fact, David Cutler, an economist at Harvard, and I wrote a report shortly after the Affordable Care Act passed, saying that we really thought there were much more substantial savings in the Affordable Care Act than CBO and the Office of the Actuaries were giving the law credit for. In fact, CBO estimated that Medicare would save $510 billion over a decade, but they gave very little, almost no credit to delivery system changes like patient-centered medical homes, and even gave no credit to competition among plans in the health insurance exchange. In other words, saying that people wouldn't vote with their feet to move into lower premium plans. So we estimated much more substantial costs. So I tried to include this slide with every talk, and I noticed David Cutler is including it in every slide he has. It's kind of a "we told you so" sort of slide. But now the current estimates by the Centers for Medicare and Medicaid Services is that the savings over the decade were $750 billion. And even the director of the Congressional Budget Office is starting to say, well, maybe something fundamental is going on in the health system that is slowing down the rate of growth in healthcare costs. And maybe this is not just the recession, and maybe it's not just a temporary phenomenon. But all of these things matter hugely. If you just take what CBO was estimating 4 years ago would happen to Medicare spending out 75 years. They love doing these 75-year projections. And you think about today, the gross domestic product being about $15 trillion, 5% of that is a bit of money. It's off by a lot. So we really need to improve the methods, because it's this kind of, even the lower one that's now being used is used as a scare for why we need to make pretty drastic changes in the system, because there's really no behavioral response built into these models. They are basically pretty simple extrapolation models, and actuaries miss turning points because they don't have behavioral models. And I served on the technical advisory panel for the Congressional Budget Office through this period, and it would drive me crazy that they would say patients respond to financial incentives. If they have to pay higher deductibles, they will use less care, or they could go to cheaper doctors. Or if you tax health insurance premiums, they'll buy cheaper health insurance plans. But they never thought that if you change financial incentives for physicians, there would be an effect. Zero. They would give zero savings to things like global payment or bundled payment or blended payment or patient-centered medical home. But in fact, as David Cutler pointed out in a recent article in Health Affairs, they do notice when the financial incentives change. So the good news is that Medicare is growing slower than GDP per capita. It's growing slower than employer-sponsored health insurance per capita. So in that sense, there's not an immediate crisis. It doesn't mean that we aren't going to enter into a lot of scare talk about out-of-control costs. And what is behind that? Basically, it is the number of people. It's not Medicare spending per person that's projected to grow. It's the fact that as the boomers reach, born after World War II, reach age 65, the numbers of capitas, the number of beneficiaries increases substantially, really doubling from the year 2000 to the year 2030. At the same time, the 40% decline in fertility rates in the 1970s means that there's a smaller labor force coming behind them. So if you think about 4 workers are funding the Social Security and Medicare benefits of one beneficiary in 2000, there are going to be 2.3 workers funding those benefits in 2030. So that's basically the issue that has people's attention. So what are the proposals to deal with it? Well, the things you have to understand before turning to those, one is if the government doesn't want to pay and providers don't want to be paid less, the last option is have beneficiaries pay more of their own medical expenses. So the first thing you should know is that half of beneficiaries have incomes under $22,000. As Jerry Anderson's work has shown, almost half of them have multiple chronic conditions. A substantial number of them have cognitive impairments. A fair number of them are in long-term care, and others are disabled or quite frail. The other thing is that Medicare families spend already 3 times as much as a percent of their incomes as people under 65, so they're already spending close to $5,000 a year on their health expenses. And Medicare benefits are less generous than the typical employer plan, than the typical federal employees plan. So when you're talking about increasing the deductibles, you're talking about coverage that already is pretty skimpy with over $1,000 hospital deductible. So get ready for Medicare. I think one of the consequences of having a skimpier benefit package is that nearly everybody goes out and buys something else to go with Medicare. So employer coverage is typically the only plan you have. But with Medicare, because it has such large deductibles, people either buy private Medigap coverage to fill that in, or they join a managed care plan, a Medicare Advantage plan that has lower deductibles, or they're covered under retiree coverage that supplements their Medicare coverage, or some have low-income Medicaid coverage. And that kind of works for most of them, but it makes it pretty complex to have to go out and buy multiple sources of coverage. So you've got a private drug plan, you've got your Medicare hospital coverage, your Medicare physician coverage, your private Medicaid Medigap coverage, and you've got to put it all together. So it's not surprising that having decided to do it that way, we pay a price in the form of higher administrative costs. So Medicare itself runs about 2% administrative costs. The private managed care plans run about 11%. The supplemental Medigap coverage runs about 20%. So you can just think, if you covered the benefits that are in the Medigap plan in traditional Medicare, the savings you could achieve just in administrative savings are quite significant. So what are the reform options? I'd like to, first of all, I think we get some hints of proposals by looking back to the 2012 election, when there were some major proposals put on the table. There are even more significant incremental changes being proposed, and then I'd like to come back to some work that some colleagues at the Commonwealth Fund and I've done called Medicare Essential, and contrast it with a proposal that I think we're going to hear a lot about in the next week or two, which is Congressman Paul Ryan, who was Governor Romney's vice presidential candidate and who is chair of the House Budget Committee, and his idea called a premium support, or sometimes called a grand bargain, negotiate with the president on entitlement reform and get a big deal about spending. Okay, well, what were the options on the table during the election? Governor Romney proposed to repeal the Affordable Care Act. That means all of the benefits that were in Medicare, but also the $750 billion worth of Medicare savings. And I don't know that anybody took that really seriously, but that would have been the implication. But since that so far has not been the case, the savings are there, adding to the solvency of the trust fund, and the improved benefits continue. The other provisions, for example, while there was a freezing of the Medicare Advantage rates, there are bonuses provided to the top 4- and 5-star quality plans, and we're beginning to see movement of beneficiaries who are getting the information about which plans are 4- and 5-star plans into those plans. And certainly we're seeing a rollout of the Centers for Medicare and Medicaid Innovation, everything from comprehensive primary care, medical homes, bundled payment for care improvement, accountable care organizations. What we haven't seen is establishment of an independent payment advisory board. So that's been one of the more controversial features, which was put in the legislation to say if Medicare spending does start going up faster than the gross domestic product, this board can make recommendations for holding it in line with GDP plus 1 percentage points in addition to the overall economy per capita. And if Congress doesn't act within short order to substitute comparable savings, those savings go into effect. So that's been a very controversial provision, and so far, one of the things that requires funding, staffing, and has not moved forward. But the main provision that was not in the Affordable Care Act was doing anything about the formula for physician fees that continues to be a thorn in the side of policymakers. Okay, those were the things that were talked about in the election. What's being talked about now? Well, so far, not a lot of people are spelling out what they have in mind. But the favorites are raising the age of eligibility from 65 to 67 to raise premiums and cost sharing for higher income beneficiaries. But actually, there's already income-related premiums in the law. To merge A and B and have a higher deductible, say a $600 deductible, to tax Medigap plans, 30% surcharge on the Part B premium for anyone who fills in the deductibles with Medigap coverage, as well as getting additional savings through either penalties or provider payment rate changes. The two other fundamental options, I would say, are Congressman Ryan's premium support and what my colleagues have laid out in Medicare Essential. Both try to achieve the same rate of spending. They try to hold Medicare spending to GDP per capita plus a 0.5 percentage point, but do so in a very different way. The premium support takes a fixed sum of money and gives it to beneficiaries to buy health insurance coverage. The Medicare Essential proposal would provide a comprehensive set of benefits, but give shared savings to providers to hold total spending to the rate of increase, the target rate of increase of GDP per capita plus a 0.5. The premium support doesn't specify what the benefits would be. They say they should be actuarially equivalent to the current benefit package. The Medicare Essential proposal has a lower deductible, but particularly reduces copayment for primary care, and then in addition has reduced coinsurance for beneficiaries who seek care from high-value providers. The CBO estimated one of Congressman Ryan's this is his initial proposal, to cap the rate of growth of the premium support. He doesn't like the word voucher, so it's a fixed amount of money per person indexed over time with the GDP. And the CBO estimated that the effect of that by 2022 would be that beneficiaries would pay about $6,000 more for health insurance, because it's controlling what the amount of money going to the beneficiaries, but not controlling the total cost of care. The Medicare Essential proposal that I laid out for some of you who attended the conference in May was published a couple of days later in the Health Affairs Journal, which is this comprehensive set of benefits that combines the hospital part, the physician part, the prescription drug part, the supplemental coverage into a single benefit package. It uses pharmaceutical benefit managers to negotiate prescription prices, but it also gives beneficiaries a financial incentive to seek care from high-value providers, reduced deductibles if they get care from patient-centered medical homes, reduced cost sharing if they get care through providers within accountable care organizations, and changes the basic methods of payment to hold providers accountable for achieving cost savings. The overall effect is to save beneficiaries about 17% relative to what they now pay out of pocket for premiums, and most of that is through this administrative savings by getting all of their benefits under a single public benefit package. But those that also pick high-value providers would get 40% savings by walking with their feet toward higher quality, lower cost providers. The proposal is designed to be budget neutral in the first decade, but in the second decade, if costs are starting to rise, to really use these incentives for providers to hold the rate of growth in spending. The advantages for beneficiaries are simplicity and financial protection, but there are also incentives for wise choice of care, and for providers to better coordinate care and improve adherence and reduce avoidable hospitalization and emergency room use. So there are downsides. Anytime you shift to paying a global payment or a bundled payment, you worry about skimping on care. Will information on quality really be adequate to prevent that? Will it be difficult for high-quality specialized providers to compete if there are incentives for beneficiaries to seek out high-value providers? And in fact, will they be available everywhere? I think it goes without saying this is a bit of a tough road politically. The things I put at the highest political difficulty are negotiation of pharmaceutical prices that was written in as explicitly prohibited in the Affordable Care Act in exchange for the drug industry's support of the ACA. But the insurance industry, it basically would eventually wipe out Medigap supplemental plans, so that's threatening to that industry. And the idea, for example, of using reference pricing for medical devices, if you want a more expensive hip replacement device that's not any better than others, you pay the cost difference. We've seen one of the provisions in the Affordable Care Act that's being held out is removing a tax on medical devices that's $30 billion over 10 years. So it's a relatively minor provision, but that seems to be the price tag for ending the government shutdown. And that comes from the political ability of that industry to push for that provision. So on the other hand, there are others who may want more federal budget savings, and in any event, getting anything done in this climate when there's such sharp partisan divisions is hard. But this kind of illustrates, while both the premium support and the Medicare Essential try to hold Medicare spending to the rate of growth of GDP or GDP plus a half, the premium support holds government spending to that level, but if healthcare expenses go up at a faster rate, beneficiaries pay the difference. The Medicare Essential gives providers shared savings if they hold spending below that target rate of difference. So it's the difference between holding beneficiaries, putting them at risk if costs go up, versus giving incentives to providers to share in savings if they're effective in controlling costs. Well, lots of work, lots of research, lots of questions, lots of improved modeling that can be done to try to improve and inform this policy issue. It's obviously not going to be resolved this week, next week. It's really going to, I think, be the major topic for the next, I would say, 2 to 3 years. A lot of debate over this, which way to go. And so it's a particular pleasure to be here at Hopkins and at the Roger Lipitz Center for Integrated Care, really dedicated to try to find what I think of as win-win-win solutions. Are there ways of providing better integrated care, particularly for people with complex care needs, that will improve health outcomes, improve patient experiences, and at the same time yield savings? So that's all we're trying to do at the Roger Lipitz Center. So thanks to Mr. Lipitz and to the Dean for that opportunity, and for my colleagues, many of whom are here today, for joining me in this effort. So, and to Eva Chang, who's defending her dissertation tomorrow. So thank you very much.
Karen, thanks. You're right. Incredibly topical talk, and it sort of gave me a lot of insights into the headlines. Let me ask the first question. So the Ryan plan, which depends on basically penalizes beneficiaries if costs go up. The only way beneficiaries can reduce cost, since they don't really control the cost of care, right? They don't control how much a cabbage or a hip replacement cost, is by reducing service, right? They just don't seek services, right? Are there any other options under his plan for a beneficiary to reduce the cost of care?
That's the primary one, that there'll be cost-conscious shoppers, that things that they now seek care for that, say, are marginally beneficial, they wouldn't go for because they'd be paying for it with their own money. There are some who argue that they will go seek out lower-cost doctors. They'll go to nurse practitioners in retail clinics. They'll find a place that charges less for a colonoscopy or less for a mammogram and go to those places. So some argue that it will affect price, but the main thing is use. The other argument that's used is that insurers, once people are buying with their own money, want to get a bigger and bigger share of the market. So they will find a way to control costs and find a more effective utilization management techniques to hold down costs. Obviously, they've got those incentives now, but that's part of the argument.
Great, thank you. So I'm sure others have questions.
And sometimes there are different versions of this premium support out there. Some of them would peg the level of the support to the second cheapest plan in a given marketplace. So again, that's why people think, well, everybody would be trying to get down into the cheaper premium. Yeah.
I was wondering how much discussion is going to occur around the disabled and the dual eligible. And I notice the dual eligibles have gotten attention recently because they're so expensive when you add the Medicare and the Medicaid part together. And so I guess that question of coordination. But when you look at the overall.
Say what dual eligibles are.
Well, the dual eligibles are those that qualify for Medicare as well as Medicaid, and usually through SSI and low income. Are they going to come up in this discussion? Because otherwise it sort of sounds like it's a homogeneous group that's over 65, but yet we miss a very big port.
And I tried to lay out in the characteristics of Medicare beneficiaries just how different groups are in terms of both income, but health status, and Don has asked particularly about people who are so low income, they have both Medicare and Medicaid. One of the provisions in the Affordable Care Act was to test new ways of integrating Medicare and Medicaid funds. And there are nice models of that. Here in Baltimore, Hopkins at Bayview has something called Elder Plus that I visited a couple of weeks ago. It's called a PACE program, Programs for All-Inclusive Care of the Elderly, and it's a day center, picks people up in buses. And the basic economics are that Medicare is paying about $3,000 a month for patients who are really eligible for nursing home services, and Medicaid's paying $3,500. So between Medicare and Medicaid, it's $6,500 a month, so about $75,000 a year for the care. So the PACE program receives that amount of money, and whether people are in the hospital or not, whether they're in the nursing home or not, the program pays all of their bills, is financially responsible for all of their bills. On the other hand, they have two advanced practice nurses there, and they provide health services on site. And they even have some specialist referrals there. They also have acupuncture. So not only do they have social activities and exercise and getting people engaged and moving, but they also have good primary care accessible right there on site. And so they are able to achieve substantial savings and be able to go financially at risk, even with 150 enrollees, which isn't very many, but that's all the state will let them have. But they are able to make net. So there are these model approaches that are great for people. On the other hand, what states have in mind are quick savings. So if you take the $75,000 that Medicare and Medicaid are spending and give it to a private managed care company, and they said, we'll take care of their services, don't worry, and close your eyes. And we're going to take 20% of that off the top for our costs and our profits, and we'll use what's left to provide services, including maybe not covering the same home care aide that used to cover somebody before, or the same doctor that was covering that patient, and without a proven model of care that really is better care at lower costs. So I think the real challenge is to identify what are the effective models of care, what are the necessary safeguards to make sure you've got kind of a PACE-like outcome as opposed to take the money and run outcome. So that's actually one of the very interesting things about doing research, is to be able to look at the innovations that are out there that really are have the potential with high need populations to achieve savings.
So take the money and run, is that health policy talk? Or is that
I just had a quick question about, as far as, well, actually it wouldn't be two, it's actually two questions. In regards to Ryan's plan and the Medicare Essential, would they both be factoring in people who have lower incomes? Would everybody be receiving the same amount of money, whether they have a lot of money or they don't have a lot of money?
The Ryan proposal says they would be adjusted for health status and they would be adjusted for income. So the techniques by which that would be done aren't yet spelled out. We've actually responded recently to a request from the Commonwealth Fund to do some additional work on the income supplementation in Medicare Essential. The way we had designed this and published this is a Medicaid wraparound that would spend the same amount of money that we're now spending on Medicaid supplemental coverage, but using it to pick up this extra premium on a sliding scale for the Medicare Essential benefits. But the Commonwealth Fund Task Commission on a High-Performance Health System has a terrific member called Patty Gabbo, who was head of Denver Health, and she said, why do you make them go sign up for Medicaid and then wrap it around Medicare? Why don't you do what the Affordable Care Act does, which is just build the sliding scale premium and the sliding scale cost sharing directly into the benefit itself? So that's what we're hoping to model. What would that cost? How would you design it? How adequate? What would you need at different income levels? But yes, both would try to adjust that.
And sorry, last question. As far as disparities, are both plans, do you think, are going to consider the health disparities that already exist in Medicare? Because as a lot of us know in the room, there are differentials accessing to care based on person's racial ethnic background. So I was wondering if the Medicare Essential and Ryan's plan do start to account for these differences.
I don't really know that the premium support has given any thought at all to racial disparities. Obviously, what we've tried to do in Medicare Essential is to promote use of providers like community health centers that become patient-centered medical homes that provide culturally competent care, that use both clinicians and staff that are from the community, know the community, work with patients, get better outcomes. But a lot of this is in the detail. So if there are quality metrics that have to be met, are are they those that are sensitive to underserved populations? And one of the issues that's come up is the hospital readmissions. You have higher readmission rates when you are serving populations with lower literacy or living or homeless or have other kinds of mental health or substance abuse problems. So should you be risk adjusting the quality metrics in order to avoid penalizing those that are taking on the highest risk patients? So still a lot of work, I think, to make these proposals and these payment methods and these delivery models really successful with different, just as Don has identified the health status differences, the different SES differences, racial, ethnic differences.
Let's have the last question.
Karen, thank you. That was very interesting to get all those details. We're ready maybe for the policy debate, which is the question that I have. It seems like such a good takeaway that under the Ryan plan, the premium plan, it's the beneficiary that's at risk, right, and likely to have pretty substantially increased costs. So I just wonder, you know, moving from all of our science and good policy planning, how are folks like us going to get that message out? I mean, it seems like one of the more simple messages that we've had around healthcare and what we should be doing in terms of changing policy.
Well, I do think you can't be terribly encouraged by the 2012 election that each side said they're going to cut Medicare. And the difference between cutting Medicare by making beneficiaries pay more of their own expenses and cutting Medicare by moving to better systems of care that prevent avoidable hospitalizations and nursing home placement and emergency room use are very different ways of achieving savings. But it certainly was very, very muddled and very hard for anybody to sort out. So people just have some kind of basic gut about, is this somebody who's really going to protect the program? Because they're all going to use language like path to prosperity, essential Medicare, that have nice titles, but kind of really educating people about the implications of these pretty fundamental choices is an important communications challenge. So. Well, I think one thing is to kind of look at the language that goes into this. So a lot of it is, do you want to decide for yourself what you want to have, or do you want the government deciding for you? So that, what are the kinds of messages that get crafted that make one strategy seem appealing versus another? But certainly CBO's estimate that the average Medicare beneficiary would have to spend $6,000 more every year on top of, what they're already spending, caught people's attention and kind of made it go away for a while as a proposal. But I think it's coming back.
But I think the argument should be get the fat out of the system, right? If you simplify Medicare so you reduce administrative costs, that's fat. We could sell that.
Right. And particularly administrative costs. Nobody
likes
wants
administrative.
to have their money wasted on administrative.
I mean, the faculty are always getting on me about administrative costs. So I know
You've heard
nobody
it
likes
too.
it. So, Karen, that was great. We all learned a lot, and we really appreciate the talk, but appreciate all you do for us here at Hopkins. So thanks. And we have wine and some food outside, so we can all go out and talk to Karen one-on-one. Thank you.